Well, once again, I'd like to thank the organizers for inviting me. Now, earlier, Dr. Kislow told you that the lectures today are from highly experienced operators. But let me tell you that when it comes to implanting experimental percutaneous mitral valve prostheses, there are no highly experienced operators, because it's universally been very difficult to find patients for these studies, and you have to be very careful. So here's my disclosure. I don't know who the best patients are, and I think over the years we'll see this continue to evolve. Now, I'd like to point out that we are nearly 100 years out from the first mitral valve surgery, published in what later became the New England Journal of Medicine, and we are 63 years out from the first mitral valve replacement. So I think we have to learn a few things from what's been done before us. So first, bioprosthetic valves are preferred over mechanical valves in the elderly because of lesser requirements for anticoagulation. Mitral valve repair is preferred over mitral valve replacement in primary MR in appropriately skilled hands. And I won't go into the details as to which ones are preferable, but that's what our guidelines tell us. And finally, mitral valve replacement is more durable than repair for ischemic MR, but compared with medical therapy, Mitraclip is the only proven therapy for secondary MR. The only positive randomized trial that we have for secondary MR is COAPT. We've heard a good deal about that. And we've heard a good deal about these two trials. I will not reiterate what has been said, other than the one thing we've learned from COAPT compared with MITRA-FR is if you're going to repair a mitral valve, you'd better be sure that there is significant mitral regurgitation present, and I would say that's probably doubly true if you're going to consider a percutaneous replacement. So look, right now Mitraclip is the percutaneous treatment of choice for mitral regurgitation when it can be performed. And I hate to say this standing in front of Saibal Kar, but there are contraindications to Mitraclip, and these are taken from the instructions for use package. Chimachural jet location, mitral valve area less than 4, calcification in the grasping area, leaflet cleft, or large flail width or gap. And I think, given the time constraints, we ought to proceed quickly. So the things we keep in mind when screening, and screening, I'll tell you, has been very difficult, are guideline-directed need for mitral valve surgery. And truthfully, at this point in the development, we have to be very strict about which patients we include. High risk for open surgery. Open surgery has got a long track record. Patients who are not suitable for Mitraclip, patients who meet appropriate clinical criteria, and patients who are anatomically suitable for percutaneous valves. And these latter two have been serious challenges. So the ones for which we have the most data are the Tendyne Valve, shown here. You've heard about it. It's an annular valve with an apical button that serves to anchor the valve in place. And Intrepid, which is the valve that our center has worked with. Again, it's an annular valve. Shown here is the insertion technique. And we've got some echo clips of valve placement. Shown in the lower right is a 3D rendition of what the valve looks like when you're complete. So this shows you the paradox of this kind of technology. For an annular valve, something surgeons know well is our concern is displacement of the anterior mitral leaflet into the outflow tract. So ideally, you want patients with large ventricles. The downside of that is these valves require a large apical ventricular incision. So the patients you want are, in large part, the patients who can't afford to have a piece of their apex damaged by the surgery. So that has been our primary consideration in selecting these patients. So one thing that I think is very favorable is if you look at early experience with these valves. So these are the first 100 patients in the global Tendyne study reported here. There is perioperative mortality, but what's encouraging is that that mortality increment doesn't continue. And similarly, mortality with the Intrepid valve looks the same. The mortality is front-loaded. The concern was that as the mitral regurgitation is reduced, as it is very effectively with both valves, and ventricular size decreases, the risk of LV outflow tract obstruction would increase. But we don't see that in the mortality figures. So what have been used to select these patients? And I'll use just the published data from the two clinical trials that have been, the large clinical trials have been published. So Intrepid and Tendyne, very similar. Symptomatic severe MR, high surgical risk. These patients have to be anticoagulated, so the ability to tolerate warfarin is important. And particularly, that's a little tricky in the high-risk patients who may also be at high risk for bleeding. Exclusion, again, in both trials, reduced left ventricular ejection fraction, vastly dilated vessels, vastly dilated left ventricle, elevated PA pressures, severe calcification, intracoronary thrombus, the common sense things that you'd think would exclude patients clinically. And when you look at the published data, you'll see that the screen failure rate has been fairly high. Of the virtually close to 500 patients, only 30% of patients screened are accepted for trials. And remember, this is after going through, screening begins after going through an algorithm that includes consideration for Mitraclip, which really has worked its way into the accepted standard of treatment for percutaneous mitral valve therapy. So even after going through that, that algorithm whereby patients who are suitable for Mitraclip are taken out of the equation, we're still able to enroll only about 30% of screened patients. Many of the exclusions are clinical, many are anatomic, as I'll show you. So these are the anatomic considerations you go through. Take a high-resolution CT scan, and there's a 3-Mencio program that's available that you can use to perform the measurements and calculations. Unlike what we do with the aortic valve, which takes about 5 minutes on a slow day, this takes about an hour on a rapid day to get all these segmentations and measurements completed. And this is what's done. We measure the aorticomitral angle, we measure the LV thickness down at the periapical access point, and we measure the height of the annulus. And then there are charts, and no one can remember this. This is why these charts are printed on paper that tell you this relation of the size of the valve based on annular size to what is an acceptable range, generally with about 10% oversizing planned.
1 minute.
And then to consider the possibility of LV outflow tract obstruction by the anterior mitral leaflet, what we do, or what's done, is the neo-LVOT is constructed, shown here. And what you do is you take a model of the valve, shown in yellow, superimpose it on the 3D CT rendition, and then measure the area of the neo-LVOT, the new LV outflow tract. Now, one thing that we've learned along the way that we didn't know early on or didn't think of, we should have learned from our echo colleagues, and that is most ejection occurs early in systole, before the ventricular size really has contracted. So really, the flow is weighted toward the first portion of systole, And it's really the diameter or the area of the neo-LVOT in early systole that is used now as a decision-maker. And if we went back to prior patients, we might have included more patients knowing that fact. But here's what the algorithm looks like. An assessment of end systole. If the neo-LVOT is more than 1.5 square centimeters, that inclusion of that patient is recommended. Then there's a multi-phase assessment looking at variety of increments during systole, and those are averaged. And if the average is 1.5 centimeters squared or more, inclusion is recommended. And then there's the early systolic assessment that also is a weighting factor in this assessment. And if it's greater than 1.6 square centimeters at the 10% systole phase, that patient is reviewed further just to make sure that there's not abnormal contraction of the neo-LVOT late in systole when the valve is compressed and the ventricular dimensions are smaller. So here, for example, is a patient in whom that does happen and in whom rejection for inclusion in the Intrepid trial was recommended. And as you can see, we start off with an LVOT area of 1.5 square centimeters, but in late systole, it's about half a square centimeter. And that gets a little dicey, and that's the sort of patient who is screened out. So I'm out of time. This is a complex area. It's been very difficult. It's going to evolve very rapidly as we get more experience with these valves. So I'd like you to keep your ears open. Thank you.
Thank you so much, Professor Kleiman. Since we're running out of time, we have 30 seconds for a quick question or comment, please, from the audience. Is there any question?